मेरे साथ 2013 जिनसे डायबिटीज की तो साथी था कोचिंग मना करते गए तो सरकार ने
Very good morning. I'm very happy to be here again and again in this very auspicious Vadodara. And I thank the organizers for giving me this wonderful opportunity coming to hypoglycemia in pregnancy, which is a very important thing. Before insulin era, if you say take pregnancy, it's totally contraindicated because and thought as an added complication compatible with life. But because the mortality was very high, but with the advent of insulin, the scenario totally changed and insulin became the drug of choice for diabetes in pregnancy, which is safe both for the mother as well as the child. If you take the normal pattern of glycemia according to Hernandez, he studied in about more than 1,000 cases and saw that fasting is always less than 80 in pregnancy, not like non-pregnant state, and 1 hour less than 122 and 2 hour always less than 110. And so our Tipsy has a target of fasting always on premeal less than 90 and postprandial between 110 and 120 and the mean glucose level between 95 and 105. To have the normal weight of the baby, that's very important. It should be between 2.5 and 3.5. And American Association of Clinical Endocrinology, they are still stringent. They say that 1 hour has to be less than 1, not 2 hours. 1 hour all we throughout the day, it has to be less than 120, they say. And they have a strict HbA1c of less than 5 for GDM and for the diabetic, of course, less than 6 and all premeal less than 90. And even if you take the time range, you see it's very strict for GDM and type 1 or type 2 diabetes, more strict for type 2 diabetes and GDM. They have to be within the range for a very long period. And whatever Jocelyn says, that glycemic control has to be maximized to the extent that the fetus no longer recognizes that its mother has diabetes, then the treatment of mother during pregnancy becomes the first step in the prevention of obesity and diabetes in the offspring, so that we will not have all these conferences they could have won. And Arnold Langer, he says, don't worry about the dose of insulin, what you use, it is appropriate to use the maximum dose, that is the insulin required to achieve the target rather than worrying about the insulin dose. You concentrate on the blood sugar result. And another terminology, maximum tolerated dose, that is administration of this fast-acting insulin, TDS, 3 times daily, going for the maximum tolerated dose. This is the highest quantity to prevent the complications much better. They have done a study and found that LSCS and the preterm macrosomia are very much less when you go for this maximum dose. And truly what he says, he has seen so many hypoglycemias, that is hypoglycemic coma is more common during pregnancy, and he has said it's not a harmful, and they have records of 100 pregnancies in which hypoglycemic coma occurred at least once without any effects for the mother or the baby. And see, this fetus is a continuously eating odor, intermittently eating towards the mother. So she very well goes for hypoglycemia. So the problem with treating hypoglycemia, the other side of the coin, is hypoglycemia. And what is the level? We say that this is hypoglycemia. Fasting, not like non-pregnant, it's still less. And if you see time range, can go up to 54 also. Fasting less than 63 and 1 hour less than 81 and 2 hour postprandial less than 72 is hypoglycemia. If you see these levels, they are alerted. And another thing is, the fetus waters that it steals glucose from the mother. It cannot produce glucose by itself, and what happens? Initially, the fetal renal threshold, if you take it, is 110. Whenever the mother's blood sugar crosses 110, the fetus starts reacting to it by secreting insulin. So the insulin which is started secreting never stops, continues. This hyperinsulinemia persists. Initially, it tends to reduce the blood sugar, but later this hyperinsulinemia causes more hunger and steals the glucose from the mother as long as it is inside the mother. So the mother can go in for hypoglycemia, and the placental transfer of glucose is increased by group 1, which is more during pregnancy, and is the reason for development of maternal hypoglycemia. And as you said, the fetus cannot synthesize the glucose but uses it as a main oxidative substrate, and the fetal glycemia is always lower than mother, so it has to get from its mother. And hyperinsulinemia again steals glucose from the mother because it's a continuous and ever-going process. Even after birth, the child has hyperinsulinemia and keeps on eating more hungry and puts on weight and getting obesity and all that problems. And the lady, once the umbilical cord is cut, once it is born, it goes for recurrent hypos. This is what we see in our practice. And if you see in pregnancy, the fasting is always low by 10% compared to the non-pregnant state. We used to diagnose pregnancy, and in the OTtions we used to say she is conceived in infertility cases by seeing the continuous fasting. If it comes down, that means she has conceived. The early weeks, the rise in estrogen improves the insulin sensitivity, and also the fasting is low. The net effect of anabolic changes due to increase in plasma volume in early gestation, increase in the fetal-placental glucose utilization, and fall in amino acids. What happens? It is the substrate for gluconeogenesis, substrate deficiency syndrome. And remember one thing, soon after conception, the insulin dose comes down. So you have to reduce your little 0.8 units per kg, it comes to 0.7. If you are not reducing, she will go for hypoglycemia. As the pregnancy advances, she needs more and more insulin because of the hormonal influence that you have to carefully monitor and increase the dose, otherwise you go for hypoglycemia. And what are the risk factors? Of course, long duration of diabetes and history of previous episodes. They get into recurrent episodes very easily, and some cause for hypoglycemic unawareness, and change in the insulin's treatment, like changing the regime or dosing, you have to monitor carefully. And severe hypoglycemia, of course, very common in type 1 diabetes because they don't have adequate glucagon also. And if you see this, both the pregnancy and diabetes, it affects the insulin levels to fluctuate. So you cannot predict when they go for hypo and when they get that hypoglycemia. The lifestyle factors like not eating enough, exercising more than usual, or taking alcohol, having an eating disorder, or they may vomit continuously. And whenever you see, of course, as I said, they can tolerate pregnant, they can tolerate hypo well, but sudden decrease in hypo, you should suspect fetal childbirth. That means the placental thing has gone, and you should suspect hypo. And in the final weeks, of course, the blood sugar level comes down because of the growing fetus consumes more glucose from the mother, and after 10 weeks, at 11th week, as I said early, is the fetal secretion of insulin, hyperinsulinemia, which is triggered because of the increased glucose in the mother, will not stop. Once triggered, it will continue forever throughout the pregnancy and in the future life, also leading to obesity and all other problems. And you should remember, when the active labor begins, the insulin infusion used in the pre-GDM has to be lower. And in contrast, GDM, the placental detachment totally cuts off the hormonal influence. These cases, you have to be very cautious in reducing the dose or stopping the insulin infusion at the time of delivery, or else you go for severe hypoglycemia. And another thing you can see, that after it is, that is the regular insulins, the conventional insulin, they are not coinciding with the food absorption. They have a delayed peak, which is not coinciding with the absorption of food. So they have unwanted hyperglycemia at the same time, at the level of peak, they go for hypoglycemia. So they tend to snack more, you'll be increasing the dose of insulin, again she'll go for hypoglycemia. This becomes a vicious cycle. So you have to teach the patient, pregnant lady, about the timing, half an hour before it has to be taken, so that it coincides with the food absorption. So the better thing is our analogs, which has the better peak, it's coinciding almost with the regular physiological insulin secretion. The more is the Fiasp. Fiasp is more like a physiological insulin secretion. See, this is the regular insulin what we have. It has a delayed peak and also not coinciding the physiological insulin food absorption. That is the secretion of insulin. And fast acting is better than our regular. Whereas if you go for the Fiasp, it is more closer to the physiological insulin secretion, so that the patient will not have much hypoglycemia. And again, if you come to the basal insulin, The NPH is nothing but contaminated. Regular. So it will also have an unexpected peak. So we cannot say when the patient is going for hypoglycemia, whereas the determinant and recent degree they are better. In hypoglycemia, in pregnancy, determinant favors improve glycemic control with reduced risk of hypoglycemia because of the lesser peak compared to NPH. Whereas if you go for degluten, it has a very flat, so that the patient, we are using it practically and we are not getting that much hypoglycemia compared to the NPH what we used early. It's very good with that. In case of type 1, so it is very pretty because we don't have adequate glucagon also, we cannot predict where she goes for hypo and hyper, so better go for insulin pump. And now, in the first trimester, you can expect hypo because of hyperemesis. Type 1, the chances increases by 3 times, it's more common. Mostly there is a fear of second trimester, but still taking precautions is mandatory. And before, if they go and have hypos, they are prone to get recurrent hypos during pregnancy. And being sick, one may lose appetite, resulting in use of existing sugar levels, which could result in hypoglycemic episodes and malnourished. It should not be undernutrition or overnutrition. Both should not be there. Lack of nutrition and calorie content of food could increase the risk of hypos. And in the mother and child, if you say only frequent, recurrent, prolonged severe hypos can cause mental retardation and physical abnormalities. That is, some changes in the cognitive dysfunction can occur, and also physical abnormalities. Women who have severe hypoglycemia may need to be hospitalized and monitored. Blood sugar may drop dangerously low shortly after birth, and cleaning due to the relief of stress by the expelled placenta, and pre-GM may be improved, not reducing the dose of insulin. And severe hypoglycemia is common in pregnant women with type 1 diabetes treated with intensive insulin therapy. And how to prevent, of course, frequent home glucose monitoring. Now everybody are familiar with that, and educating regarding the symptoms of hypo before it occurs, and better use analogs which has more physiological and has less hypos, and if possible use of CGMs and pumps. Just SMPG is enough if you teach them. According to ADA, a person who experiences low blood sugar symptoms should check their blood sugar levels often, that is before and after every meal, and in the middle of the night should not go unnoticed in the midnight, and before going to bed, and more frequently respond to changes in the medication or lifestyle, and before and after exercise. That's must. Of course, the pro, of course, it will show like this. That is next with the value along with that, it will show whether it is going to increase or remain the same, or it is going to decrease. All these arrows will come, so that you can be cautious whether she go for hypo or it will remain like this or not. And our pet dogs, of course, always with us and sense hypo better. This is another thing. And how to reduce, of course, eat small frequent meals. Well balanced diet should be more of proteins and protein-rich diet, especially the night, because she's going to fast for a long time. While sleeping, it is a long fast. Keeping the snack by the side is very important. And indulging in moderate exercise, not too much, should be avoided. And it can be again prevented by modifying your dose of insulin, diet changes, and breaking the 3 meals into 6 small frequent meals, and adding more protein to the carb and making it a lengthy carb. All this will help. Of course, ability, the blood sugar you see, the patient will be alright. If it is less than 70, and if she is conscious and alert, give something glucose containing fluids like fruit juice, soft drink, crackers, or she can even go for a regular diet. If you see this without any symptoms, and repeat the glucose after 15 minutes, it's okay. If it remains the same, you have to again give her something to increase the level of blood sugar. If she is severely confused or unconscious, of course, go for dextrose infusion and also glucagon if necessary, and she has to be hospitalized. So, first and foremost, you teach her to all the symptoms of hypo and be ready to face hypoglycemia anytime. And whenever you have given something to treat hypo, monitor the blood sugar after 15 minutes. If it is still low, you have to repeat what you have given. and until the blood sugar comes to normal, keep repeating and keep measuring the blood sugar. And if she's not recovering with all the IV takes, so 50%, 50 ml or 25%, 100 ml, you can go for hydrocortisone IV bolus along with IV glucose, because this facilitates the entry of glucose to the neural cells. And it also, in all these measures, pains and she lacks up in cerebral edema, just give dexamethasone and not mannitol. Mannitol is not indicated. And glucagon, of course, it is less useful because it stimulates endogenous insulin secretion and sometimes can aggravate alcoholism. So you always combine glucose with glucagon. But of course, the merits are gives a smoother blood glucose regulation, no externalization, no venous thrombosis, and no severe hyperglycemia. And another thing you should remember is hypo from low oxygen to availability and not because of the blood glucose control per se. So administration of O2 and hypo also can prevent the manifestations of hypo. And we should also remember the other causes of hypo in pregnancy. Then see if they are on drugs like aspirin, sulfonamides, sulfonylureas, hepatic renal, cardiac failure, sepsis, trauma, burns, malnutrition, hormonal deficiencies of cortisol, glucagon, epinephrine, and any non-islet source. Sometimes, rarely, all this can occur. Non-islet tumors, IGF-1 secreting tumors, insulinoma, insulin secreting tumors, and non-insulinoma pancreatogogs, the post-gastric bypass hypoglycemia, because nowadays all are obese and they go for these gastric surgeries. Insulin antibodies sometimes there, and insulin receptor antibodies, and some features of malicious hypoglycemia. All these also you should just keep in mind, but common things are always common. What I said early is important, but also have this in your mind. Thank you.